So I've been tasked with the topic of image overlay for tricuspid regurgitation success. These are my disclosures. So there are clearly intraprocedural challenges for tricuspid valve imaging. We look at 4 components of the tricuspid valve. We're looking at the leaflets, the commissures, as we just saw, the subvalvular components for some of these complex technologies. We're looking at the annulus for annuloplasty devices, and we're looking at a lot of the adjacent structures. All of these have imaging challenges when it comes to TEE. If you look at the leaflets and commissures, we know that the RV and the annulus dilates in an AP direction away from the transesophageal echo probe, with the leaflets being tethered. It makes it difficult to obtain the proper windows of these leaflets with that anterior location, that anterior dilatation, that push outward. In addition, you're looking at 3 leaflets, not 2, like the mitral valve, and the shape and sizes may vary. If you look at the annulus, it is a typical inflow annulus, D-shaped, saddle-shaped annulus, but as it dilates, it becomes planar and circular. And this dynamic structure does change shape with the cardiac cycle and with device manipulation. Looking at the subvalvular components, we know that the anterior papillary muscle is the largest component of the tricuspid apparatus that supplies cords to both the anterior and posterior leaflets. The septal leaflets typically go right into the septum with a small posterior papillary muscle. The challenge with these cords is that they interact with devices, and they can be very hard to see as you're applying devices that traverse the tricuspid annulus. In addition, we're looking at adjacent cardiac structures. We're looking at the right atrium. There's dilatation of the right atrium, which may actually make this a little bit more challenging. We're looking at other structures, coronary sinus, the right coronary artery, and the AV node. It is important that we identify these structures to keep away our devices from causing any potential complication. So what are our typical modes of failure? Well, we look at annular dilatation, pacemaker wire leaflet impingement, and degeneration of the valve. And our real 3 classes of therapies that we're using currently are the annular devices. For this, we're looking at annular measurements and depth of annular tissue, looking at that leaflet hinge point to the RCA. For edge-to-edge devices, as we saw in the prior talk, we're really focusing on echo, looking at the leaflets. But now we're starting to integrate pre-procedural CT and MR as this is changing as we're learning about these newer technologies. And then finally using tricuspid, transcatheter replacement, and newer valve-in-valve therapies, and really focusing on CT imaging. And as you can see in the upper right-hand portion, with CT scans and 3D post-processing, you can actually make out the leaflets, thickening of the leaflets, and use this to help guide and plan interventions, in addition to our typical 3D TEE with color Doppler. So what are some of the technologies that we use to direct, and what do we need to know in imaging to be able to help guide and have success with these interventions? The TriAlign is a 2-pledgeted suture technique that implants at the annulus in 2 locations to plicate it. The Cardioband tricuspid valve annuloplasty system actually screws in the device within the posterior annulus from trigone to trigone to cause annular tethering. For the edge-to-edge repair technique, as we saw for the clip, we're really looking at leaflets. We're looking at bicable views for navigation of the device, and we're looking at short-axis views as well as TEE or ICE to allow us to orient the clip. And if you look at now newer 3D volume intracardiac echo, you can actually use intracardiac echo to help orient the device, and you can see nicely images within the right atrium to even grab leaflets and to ensure that you have secure clip attachment. For transcatheter valve-in-valve, really the focus has been, say, CT to ensure that we're choosing the appropriate valve size, appropriate angulation of deployment, in addition to appropriate location of valve access, whether it's from above or below SVC or IVC delivery. Well, what have we done in the past and what are we doing currently? Well, we're taking our pre-procedural CT, our echocardiogram, we're merging it in our heads and overlaying it onto X-ray for a therapy, and this is one case of a coronary sinus indirect annuloplasty device. How we take our imaging, plant our device therapy, and implant it with this imaging in mind. This is when I first started to think about fusion imaging, and this is just one case looking at a BioCore device where you can barely see the mitral valve in this location, but using fusion imaging technology, you can actually use that to help deploy, in this case, a Melody valve in the mitral position. The question to you is, which imaging approach would you prefer while you're implanting a complex device in a native mitral, or in this case, a tricuspid valve? Looking at our current technologies, we're using 3-Mensio to post-process to do annular sizing, to identify the RCA, to identify important intracardiac structures, and we're able to actually post-process images, as you can see on the right, with our fusion imaging technology. So here, doing a 3D segmentation of RV in orange, right atrium in red, segmenting out in purple or pink the aorta and the right coronary artery, you can landmark on this segmented image where your annuloplasty ring should be, where your tri-clip device, if you want to clip the septal and anterior leaflets, or an appropriate location for your trisense device to do appropriate annuloplasty. So how does this look? This is an early tricuspid valve-in-valve intervention at our institution with a failed tricuspid biological valve, and a patient had a mechanical mitral. But you can reconstruct the CT, this sort of pre-procedural plan. You can print models now to help choose valve or type of device deployment, as well as direction of access. But you can see that once you merge the technologies, and this is limited for just even a tricuspid valve-in-valve, that you can mark off the location of the tricuspid prosthesis to be able to help position and deploy a device. Intracardiac echo is now being used at a number of institutions where you can have a direct line access to the tricuspid valve. And you can see our multiplanar reformant images that help give us good identifiability of the tricuspid leaflets. We're working to this model now to improve workflows, to improve the diagnosis on TE, to improve planning tools on CT scan, and more importantly, to take this imaging into the laboratory to improve our guidance, both with CT fusion as well as echo fusion in this space. So to summarize, there's been a rapid evolution of transcatheter therapies for TR, brought about by the improvements in both mitral technologies as well as inflow imaging. Pre-procedural imaging is key, with eventual future planning for optimal views in any modality that gets the appropriate information to address this disease state and for that particular patient. TE with multiple views in conjunction with ICE or even TE alone will help drive delivery, and I think the role of fusion imaging, where we have image integration for true augmented reality, will really be an important tool for the success of therapy in this space. Thank you very much.
Excellent talk, as usual, Chad. The next speaker will be...
You want to comment, Joao?
Yeah, just
a question from the audience here.
Make a quick comment here, Molly. Phenomenal images, Chad. Just a quick question. In terms of the methodology for the CT acquisition, I think it's important also to bring to the audience here that this is not like scanning TAVR patients. Patients that have severe TR tend to have very low output. And can you comment on that as well? Because we have seen through the core lab other sites, and the scans are just like, a flip of a coin.
So for us, it's not like filling the left side of the heart. So you have to fill the right side. So timing is key to the acquisition for these studies. But as you can see, even in my 3D reconstruction, we've slowed down the contrast injections so that you don't get streaming of the contrast on the right side of the heart. But you do get a lot of artifact in a lot of the CT studies with streaming of contrast on the right side with the TR.
And the other quick one is in patients that have devices, so be that pacemaker lead and things like that, how good is the fusion? Does it help you out as well?
For circumventing around, like, for example, pacemaker wires?
Yes. Uh-huh.
You see these devices, so I think the value of the fusion technology, you see those devices on X-ray. So I think as you use the fusion, you can navigate around them just based on X-ray technology. I think it really adds value when there are things that you cannot see, so the fluoroscopically silent things. So looking at and directing towards the leaflets where you anchor for an annuloplasty device, this is where the true value of this is.